got a chance to talk about this condition, correlating inflammation and neovascularization. The question is, where do they meet? And when we talk of inflammation, usually we remind of uvea people, but actually we are not talking of uvea inflammation, but we are talking of something else. And that is precisely the point which we want to make out of this presentation. And my job is to give you the introductory concept. Why this question of talking inflammation and neovascularization? Because they coexist in the retinal diseases. Now the question is whether they are continuum of the same process. That means angiogenesis, is it continuation process of inflammation or not? So we all know this basic cascade of hypoxia related going to VEGF release and then angiogenesis. But the time actually has come when we start talking beyond VEGF. So once you go into a literature survey, as you are from academic background also, you will find that a lot of activity is going on in this field. We know that VEGFs don't treat all neovascularizations. Steroids have been used successfully in the treatment of neovascularization and DME. And neovascularization associated with uveitic retinal diseases get treated by steroids and antimetabolites. Hence, we need to look into the etiopathology. When we treat, as usually the clinicians would say that I am into the treatment part, why I need to look into the etiopathology? Because if you do not understand the etiopathology, you will be treating, but the treatment improves if you learn the etiopathology also. And it also opens vista for new treatment like topical and treatment and oral treatment, even oral treatment for diseases like CNV, they are in the pipeline and the future is not very far off. So what we know that earlier we thought that retina is immune, it's not related to immunity, but it's actually an immune privileged organ and there are so many cells which can react when there is injury. So retina can react to injury. And injury can be of two types. One is autoinflammation, where it responds by the tissue itself, and there is autoimmunity, which is because of the classical T cell, B cell and cellular mobility. So that means we need to understand that there are two types of inflammations. One which we see in uvea cases, that is the visible inflammation, and other is a low-grade chronic inflammation, which is also known as intracellular edema, and which is responsible for a lot of diseases, which is consistently found in diseases like AMD and diabetic retinopathy. So we are talking about AMD, diabetic retinopathy, vascular blocks, EOS disease simultaneously, keeping them into one frame. And that is the interesting perspective of this particular thing. Let's take the example of hyperglycemia. These are the pathways by which, and at the point which I want to make out of this slide is that these are all mediators of inflammation which are present in diabetic retinopathy. So in diabetes, these are the chemotactic agents which are released, which produces a pro-inflammatory environment, which generates apoptosis and ischemia. And VEGF release is also there. So this produces a low-grade inflammation which is responsible for your blood-retinal barrier dysfunction and then related things which happen in diabetic retinopathy, which we don't need to discuss. So we come back to the same slide from where we started. We knew that hypoxia, VEGF release and neovasculogenesis is the final path of angiogenesis. But what now we need to understand that before that there is a lot of activity which is responsible to go up to this stage. And interestingly, there is an alternate pathway also. So the inflammatory mediators can route through VEGF release and go for angiogenesis, and they themselves may be responsible to do new angiogenesis. That's the very interesting finding which I got when I went for a literature survey. So that is the interrelation of inflammation. When we talk of retinal inflammation, we are not talking of uveitis, but actually we are looking into the basic angiogenesis per se. That's the most important part of this entire presentation. So we use a term RINC, retinal inflammatory neovascular conditions. Thank you. So with this background, I will call Dr. Manish to talk about various clinical scenario, and this is entirely a new thing, so naturally I didn't want to go into a lot of etiopathology and mechanics and all those things. So to make it interesting for everybody, we will see what common diseases are present with inflammation in neovascularization. Clinical picture, Dr. Manish Tandon.
Thank you, Malay sir, for including me in this instruction course. And with all those present, I welcome you all. So we'll be, the topic given to me was retinal conditions with vasculitis, macular edema, and neovascularization with a clinical walkthrough. So we know that retinal vasculitis is the inflammation of the vessel wall. It is a clinical diagnosis which is associated with inflammation or ischemia of the retina. However, we cannot take a tissue biopsy from the retina for obvious reasons, and we need to have a systemic vasculitis to get a biopsy and confirm the diagnosis. It may happen in association with the retinal vasculitis can happen, not always as a rule, with systemic vasculitis. It may occur as secondary to infectious or a non-infectious intraocular inflammation, what Malay sir was talking. When it is associated with infectious etiology, there are associated changes in the retina, which include but are not limited to retinal vasculitis, retinal whitening or chorioretinitis, as we will see. The clinical classification that we get is the retinal vasculitis associated with primary systemic vasculitis, in which we have two conditions: one retinal vasculitis with variable sized vessels and one retinal vasculitis with exclusive small sized vessels. In variable sized vessels we have Behçet's disease and SLE, and in the exclusive small sized vasculitis we have conditions like Wegener's granulomatosis and Churg-Strauss syndrome. Then comes the second, retinal vasculitis associated with infectious, non-infectious diseases like tuberculosis, syphilis, organ-limited vasculitis like birdshot chorioretinitis, Eales disease, idiopathic retinal vasculitis, aneurysms and neuroretinitis, that is IRWAN, and the last is retinal vasculitis from a putative identifiable trigger like drug-induced, vaccination-associated, what we saw post-COVID, and tattoo-related vasculitis we are aware of. These all images are taken from internet. The retinal vasculitis associated with primary systemic vasculitis with variable size vessels, we have two conditions: Behçet's disease and the along with Behçet's disease, SLE. So we get the classical oral ulcers, we get the classical mobile hypopyon, which could be bilateral, and then we have occlusive vasculitis. So Behçet's disease affects the Middle Eastern, Mediterranean and Asian descent people. It is an occlusive vasculopathy, that is the vessel actually gets blocked. The medium sized vessels get blocked. Manifestations, we all are aware that oral and genital ulcers are there, erythema nodosum we see, pericarditis, meningoencephalitis. Ocular involvement may have anterior uveitis with a shifting hypopyon, the classic description, papilledema, and occlusive vascularity. Treatment is corticosteroids along with immunomodulatory and cytotoxic agents. Now there are adalimumab. I was just in the UVA symposium where they were talking a lot about this drug, and inflimixab, and have been shown to be effective. SLE is a secondary vasculitis of variable size vessels, classical butterfly rash, what has been described, optic neuritis, and cotton wool spots. But most notably, these patients do not have anterior uveitis or any form of vitritis. The treatment combines immunosuppression with anticoagulation. In reports of retinal ischemia, the laser photocoagulation and intravitreal anti-VEGFs have been shown to improve the outcome. Again, the images have been taken from internet. Then small sized vessels we come to. This is a rare, but these are the ones where people die. Actually, death is known in these conditions. These are Wegener's granulomatosis and Churg-Strauss syndrome. The ophthalmic manifestations include conjunctivitis. I have a case report on Wegener's granulomatosis when I started my fellowship. So the patient had specific peripheral ulcerative keratitis along with some amount of chorioretinitis with vasculitis. This is known in Wegener's. Churg-Strauss will have eosinophilic vasculitis along with SLE-like picture. Then we come to the conditions where infectious and non-infectious causes are there. And infectious etiologies can cause retinal vasculitis through direct or indirect mechanisms. Direct invasion of the vessel wall is known in Treponema pallidum, that is syphilis, rickettsia, Epstein-Barr virus, tuberculosis, and Bartonella. We are aware that vasculitis associated with infection of the retina and choroid occurs very commonly in syphilis, tuberculosis, and herpes family. This was something which because we see a lot of tubercular vasculitis, so I just thought dwelling into the detail of it. The collaborative ocular tuberculosis study evaluated 962 patients, of which only 59 patients had a PCR done. And of those who tested negative for PCR, 30% of those patients had systemic disease, including miliary tuberculosis, tubercular meningitis, and that showed the limited result, the limited kind of sensitivity of PCR test. At this time, the diagnosis of tubercular uveitis is primarily made by the clinicians based on the constellation of clinical and systemic symptoms. Organ-related vasculitis is limited to the retinal vasculature, managed by systemic interventions. Conditions like tuberculosis, herpes, syphilis, we require to treat specifically. Non-infectious conditions like sarcoidosis may also present with organ-limited retinal vasculitis. These are a few of my patients. Now we get the classical inflammatory vasculitis in these patients, and which has macular edema. We treated this patient with intravitreal Ozurdex. You can see at 1 month there is at the macula. Yeah. At 1 month we had this the resolution of the vasculitis element over there, and we have a macular star-like picture we developed. And in the next 3 months, this macular star-like picture disappeared, and so did the edema. So these patients responded well to intravitreal steroid. Eales disease is an obliterative vasculitis of unknown etiology. We all know the fundus findings, sheathing of the vasculature, and it affects more venules more than the arterioles. Capillary non-perfusion and neovascularization, vitreous hemorrhage is known, and so is TRD. The treatment for recurrent vitreous hemorrhage, the hallmark of Eales disease, is usually vitrectomy. However, intravitreal anti-VEGF has been tried. Corticosteroid injections intravitreally are given for macular edema. For drug-induced, vaccination-induced vasculitis and tattoo-induced, we have to be careful with drugs like methamphetamine, trimethoprim and sulfamethoxam, what we call as Septran, herpes C and interferon treatment. The treatment but naturally includes the removal of the inciting agents, intravitreal systemic corticosteroids and immunosuppressive therapy. This is a very interesting phenomena where we document the patient came in October 23. The patient only had some amount of vitreous inflammation and an epiretinal membrane, a low grade inflammation. So this was not a warranty for treatment. We tried to investigate the patient and the patient was kept on oral ATT. Now the second picture is of the November 23. You can see that there is a very clear-cut vasculitis now developing in this patient and epiretinal membrane becomes prominent, but there was no macular edema, so we didn't treat. And in January, the patient actually had a proper macular edema. So this is how macular edema in a tuberculosis evolves. It does not present initially the moment vitritis is there, the moment vascular occlusion is there. Macular edema may not appear. It appears at a different, and I believe you can see that the vessel block is nowhere close to macula. So the macular edema which is appearing as a result of the inflammation which is happening, not per se as what we get in CRVO or a BRVO. It is a aftermath. So that is why these patients respond very well to steroids. So this is another patient and this was post anti-VEGF. This patient I chose anti-VEGF over steroid because of the hemorrhagic element, as simple as that, and the hemorrhage was it was spreading right onto the macula. Investigations, the commonest investigations we do for these patients is complete blood counts with differential counts, then ESR along with quantiferin gold, VDRL. ACE is not routinely done, but I get CT chest done, and if it is looking like, then but naturally torch infection, and with the putative in identifiable trickle, the history is the catch point. I have seen one case of post-vaccination vasculitis with the Covishield. Treatment is oral steroids, rituximab, and for systemic diseases we have to treat the systemic disease, organ limited. We can add the corticosteroids, and for the putative identifiable trigger we have to withdraw the offending agent. The treatment of the neovascularization, PRP is done. Vitrectomy may be required for vitreous hemorrhage and tractional retinal detachment. But remember, before injecting, if there is any risk of tractional retinal detachment, then beware of the anti-VEGF agents. So this is one of my patients which developed a post-laser epiretinal membrane. So these patients these secondary epiretinal membranes, they do trouble. And this patient I am planning for a vitrectomy because the vision and the media is not as clear. So vitrectomy can be used to clear the residual vitreous debris following medical therapy to control intraocular infection. Thank you so much.
Dr. Manish, just one question. As far as tuberculosis is concerned, tuberculosis and retina involvement or uveitis, what is the minimum diagnostic criteria you use to start ATT?
Sir, if the patient has CT chest findings, if the patient, MAN2 is not the decisive factor definitely nowadays, the CT chest findings have to be there, because otherwise my pulmonologist usually writes there, I am starting this on the advice of the clinician, and these patients usually tend to roam around, and then they say, why are you starting when nobody else is starting? So I usually write for every patient which have the classical clinical findings of the inflammation, along with supportive evidence like CT chest, like quantiferin gold positivity. If these two are positive, then it is like behichak, I can start these. But if there is no finding on CT chest, the CT chest is clear, then these patients usually roam around and by and large, even if you advise, they will not take ETT. The pulmonologist will will refuse the treatment.
I think very well said, Dr. Darius. What is your take? Because the thing is, I send the patient to physician, sir start कर दो. बोला क्यों कर दें जी? हाँ? तो मैंने कहा जी ये tubercular लग रहा है इसलिए कर दो. So, what is your take? Or for that matter, Doc Saab is also sitting there. You can give your feedback on this point. Mic. Mic. Kindly give the mic here.
The key is that you send it to a physician who has some understanding of the kind of pathology, because if you just send to a random physician, that's the problem. So our place, in fact, inflammation looked after by Dr. Shishir. So he has somebody who he trusts, who has knowledge of this. Otherwise, like Dr. Saab said, Dr. Tandon said, patient goes helter-skelter, and everybody has a different opinion that whether to start ATD, whether not to start. So I think having a tie-up with somebody who understands this, I think, and secondly, awareness from our side that this tuberculosis has these manifestations in the eye. Both these things help.
A short comment from your side, sir.
Yeah, I think I do corroborate with both the points. I also I do understand what Dr. Manish is saying, and he's absolutely right about it. But I think somebody who's more of an ocular pathologist and an ocular immunologist would be probably the right person to refer in these cases. So I think that way, I think having a combined this thing with them and then kind of referring with that. But yes, as far as Sir's question goes, I think as rightly said, I think at least from the physician's point of view, I think very pathognomic. Rather, even QTB gold is not something that they really take. QTB positivity to be really something which they need to start treatment for. I think it is more clinical based. So I think having a single referral person and that would be one of the better things to do. Rather, in my practice, what I have seen is that if you are following up for ocular diseases with a particular person, I think even drugs like methotrexate and all immunological treatments also fare much better with a single referral practice than this thing with a clear understanding, where the patient is given a clear understanding of the this thing. And to a certain extent, I think even to date, TB treatment seems to be something which is a taboo in the country, and that I think that counseling is very important. So I think we need to probably move from just a CT chest, from a particular diagnostic test to probably more of counseling based and clinical feature based treatment starting.
Completely agree with your point that it is the moment you utter the word that you require anti-tubercular treatment, the patient roams around. The patient starts going that somebody will say this is wrong.
They want somebody to say no.
They want somebody, they actually search for people who want to say you don't require. And that is where you lose these patients and they come up with bigger complications.
So just a question, what should be the indication to do a vitreous tap? Like we haven't diagnosed it on the basis of any investigation.
Use the mic, Dr. Vijat.
And all the investigations are normal, but I suspect clinically that this is a tubercular case. Should we do a vitreous tap to confirm?
One case, it is not diagnosed by me, but I can just share the experience with you. There was a colleague of mine who was treating a patient of intermediate uveitis which was not responding to steroids. In our city, we don't have any dermatologist. So default drug to go is steroid only. And if the patient, and this patient, most patients respond. This was not responding. So this patient went doctor searching and landed up with me. So I suggested him that you require a vitreous tap. This patient after 6 months again pops up to my clinic because I was the one who told that you get a vitreous tap done, and he kind of refused because nobody had asked. And the patient turned out to be B-cell lymphoma. So it was an intraocular lymphoma, and if it is not responding to the treatment that you are offering, then you will have to take. But no, it can never be the first go-to. Invasive procedure you don't have to do as a first go-to.
So after ruling out and seeing
After
everything,
ruling out,
then.
giving a treatment fair trial, because this patient could have very well landed up in my OPD and would have not responded to steroid in my hand either.
So let's say, put it, if just, I mean, if you just kind of turn his question around, do you, what tap would you recommend, or what cultures would you recommend to a case of vasculitis which you have taken up for a vitrectomy? For any other cause, let's say, I mean, for a vitheme, or, if you've taken up for a vitrectomy,
Like
do
the
you corroborate your findings with uh, with the sampling, with a PCR sampling or something? Would you recommend that, or?
For my endophthalmitis cases, the one we get, we do a routine, the gram stain, the KOH stain, and culture sensitivity. Other than this, I have not had the fortune of treating any patient or diagnosing a patient. So, I'm not qualified.
Actually, it is the
to this thing
conviction
further.
level of the treating doctor. है ना? So suppose if you are die-hard uvea guy, huh, then probably you may end up doing a vitreous tap also. Otherwise, I think it's very difficult. Yeah.
But sir, actually, the point is that the PCR, it picks up the dead organism. So, in fact, just before coming here, I did a acute retinal necrosis, young lady referred from Kashmir. So immediately took the tap, and now we've sent that to Shankar Nethralaya for the PCR. So what my message is that don't, even if it's not there in your city, that sample goes to SN, and SN, of course, I mean, it's not that expensive. It's okay. I mean, it's quite affordable because Shankar Nethralaya also does it as a service, and we get results quite fast. So I think message is that these things are available, and even like, I don't get it done in Delhi. When I'm sitting in Delhi, I still send a sample to Chennai. So these, if we are
That's a
looking
very
at,
useful
yeah,
information.
so if you want PCR, so VZV, HSV, CMV,
Who is the contact person for this? Where do we contact?
it's
JB.
yeah, Dr. JB and the lab, I'll give you the contact detail. It is very, very professional. You have to transfer the
Any
money electronically. I mean, the system is very
Any
smooth.
specific way of transferring the vitreous biopsy or something?
I think we don't even keep it cold. We just send it regular. The dead organism.
PCR is a dead organism, so you don't need to basically store it. There is, I think that DTDC and Blue Dart, they take the sample and send it, and within 72 hours you'll get they have a chain of this thing. So they do initially they do a simple PCR, and then they do kind of amplification of that. So then if you come with a provisional report, then they can kind of study it further.
Thank you. This is wonderful information.
So that
So I think now we can go on to the other presentation. Dr. Abhijat will discuss the basic diagnostic presentation of these inflammatory neovascular conditions. So far we have discussed the justification of this topic, why we are trying to correlate inflammation and neovascularization. We had clinical presentation by Dr. Manish, he is from Prayagraj. And now Dr. Abhijat will be discussing the basic diagnostic presentation, and then Dr. Darayus will be taking care of advanced features.
So very good afternoon to everyone. So my topic would be discussing briefly on the FFA and OCT findings, the clinical takeaways in RINC, that is retinal inflammatory neovascular conditions. So just before I begin with the investigations, I would like to let you know about what happens when there is angiogenesis, not vasculogenesis. So for instance, in this case, the inciting factor is a endothelial cell tumor, but instead of a tumor, it can be anything like ischemia or hypoxia. So for instance, we can see that this is the inciting factor. And when any factor is present and it causes any sort of inflammation, then what happens is these pericytes and the lumen of the blood vessel along with endothelium, it gets disturbed. And because of this, sprouting begins. And how it begins? It begins with formation of a stalk cell and a tip cell. So why do we need to know about these tip cells and stalk cells? Because these tip cells are the places which have VEGF receptors. And the anti-VEGF drugs which we have, or any anti-inflammatory drugs which we have, they actually act on these receptors, and because of this, the process of angiogenesis gets stopped. So this is how the tip cells start growing towards that inciting factor, and after that you can see that new vessels start to grow on. So it has a huge spectrum of diseases, but I'll be discussing about 4 of them basically, and which includes proliferative diabetic retinopathy, neovascular AMD, few vasculitis cases, and the vein occlusions. So coming on to the proliferative diabetic retinopathy first. So we all know the use of FFA is quite good in this condition, because we definitely need to know the entire CNP area so that it can be lasered well. And moreover, the important part is catching these neovascular lesions. These leaking new blood vessels need to be identified, because on the basis of this, you can quantify the disease and even diagnose it as a proliferative diabetic retinopathy. So many a times these neovascular tissues look like hemorrhage, like flame hemorrhages. But when you do an FFA, you can actually see that no, it's not an hemorrhage, but rather a neovascular tissue. And OCT again is quite important in all the cases of PDR. You can see that this case definitely shows a neovascular tissue around the disc, but when we do an OCT, we can see that there is some formation of ERM. Along with ERM and along with this neovascular tissue, there is formation of some membrane also which is attached to the disc. This causes some sort of traction, and this membrane is even attached at the ERM. And this causes some macular schisis and also presence of some subretinal fluid with a small NSD. So this OCT scan shows a retinal neovascular tissue. And the important concept to remember is presence of drill, so which is disorganization of retinal inner layers. So why do we need to know about this? Because you need to counsel your patients that if drill is present, even after injecting, if the edema goes down, patient might not land up with a very good vision because of presence of this sign. And how do we know that? So this patient would have a very good vision because there's no disorganization of retinal inner layers even with presence of edema. But when such a patient gets injected, the edema goes down. However, the inner retinal layers are all disorganized, which is drill. So the patient might not have a very good vision. Coming on to neovascular AMD. So this is again a condition which involves some sort of inflammation which leads to neovascularization. And what happens, there is late AMD, and then comes even after the cases of intermediate and late AMD, we may see some geographic atrophy developing. After this geographic atrophy, we should not stop following the patient, as these patients can now develop neovascularization. Again, FFA is a very good tool to diagnose the cases, as you may see a huge leakage spot present over the area of atrophy. So when we do, the one thing to remember about neovascular AMD is that there is variety of presentations. It can present and mimic even IPCV, which is polypoidal choroidal vasculopathy. So whenever in doubt, just do FFA, do OCT, do a clinical correlation, and then go for a diagnosis, rather than jumping onto a diagnosis and directly going for a treatment straight away. So what you need to observe is this presence of subretinal pockets, fluid, presence of choroidal neovascular membrane under RPE. A lot of intraretinal edema can be there or cannot be there. So in cases of neovascular AMD which are active, you will see presence of hemorrhage, that is present below the level of RPE or below the level of retina even. Then comes vein occlusions. The vein occlusions are again a condition which will have inflammation and may cause a lot of neovascularization to occur. Again, FFA is a very important diagnostic tool here, as you can see that this entire area is showing capillary non-perfusion, and because of this non-perfusion, again, as you remember the slide that I showed for neovascular tissue development, you can see that there's a barrier over here, rather a differentiating area over here, that this is vascular area, this is avascular area, and this is the place where that front start developing. And you can actually see these area even in the clinical image, and you can then correlate it with the FFA image, and you may confirm your diagnosis and then go for a treatment accordingly. So when you do an OCT, you can see that there is disruption of the inner segment outer segment junction or the EZ zone. There may be a scar, there may not be a scar. That depends totally upon the condition of the patient. But yes, there is a lot of intraretinal cystic fluid. So this patient definitely needs injections. But it also needs PRP laser, a thorough tight PRP laser. And apart from that, the most important part would be going for a systemic checkup. That is very important to go in patients of occlusions, be it vein occlusion, be it artery occlusion. So this is one case that I would like to highlight, the importance of middle limiting membrane. So middle limiting membrane is something that is present in the American Academy literature books, but not in our Indian ones. So as you can see the diagram of OCT, this shows yellow arrows. This is the middle limiting membrane. If you ever see a case of non-ischemic CRVO and you notice this middle limiting membrane in on OCT, so when I did a follow-up after 1 week, this happened. The case converted from non-ischemic to ischemic in a period of 1 week only, and the red arrow shows that prominent middle limiting membrane. Then, as we all know, there is something known as paracentral acute middle maculopathy, or PAM, which is the hyper-reflective inner retinal layers. And again, if we observe or we notice such a sign, you should be aware that this patient might land up with occlusions. And as with CRVO, the same findings are present in BRVO. The only difference is that it is localized to the vessel that is obstructed. Arterial occlusions won't land up with neovascularization in retina per se, but yes, they may develop neovascularization of iris and even neovascular glaucoma. So just for the purpose of showing you the OCT scans, I would like to show that in cases of arterial occlusions, there is no intraretinal cystic edema, but there is the entire inner retinal goes hyper-reflective, as you can see in the image. And as chronicity develops, we can see that these all layers become atrophic and thinned out. So the visual acuity would remain poor, though the inner retinal hyperreflectivity goes off. And similarly, in cases of BRAO, it is just limited to the artery which is occluded. And finally, coming on to the vasculitis. So this is a case of Eales disease where you can see that the patient has been lasered, but it is a very poor condition to have on, and there is such a huge area that is having non-perfusion, and definitely some neovascularization can develop here. Therefore, a good laser is a must, but yes, the patient definitely needs to be evaluated systemically, and if needed, go for an ATT also. So similarly, this is another case which shows that there is involvement of macula in the form of macular edema. And yes, you can see the extensive CNP areas present in the entire retina. Then, as sir told, another case would be IRVAN. And in cases of IRVAN syndrome, you need to notice the signs for neuroretinitis. This yellow arrow in picture A shows a macroaneurysm, and we can see a huge vasculitis area in the form of CNP areas. And finally, I am showing an image of frosted branch angiitis, where again the entire fern petal pattern can be seen, and it is observed on FFA, and the OCT would show a macular edema which can be seen in the image E if there is involvement of macula. Thank you for your patient listening.
Nice, Dr. Abhijat. Just one question I would like to ask. You said something about laser. Which area would you like to laser?
In which case?
You showed some cases of, I think, diabetic retinopathy where avascular, vascular.
Yes. So generally, I would like to follow a combined treatment, not a single treatment. Like I would inject the case also, but yes, I do FFA for one purpose and one purpose only. That is to identify the CNP areas properly, because I would laser those CNP areas, because that is the thing which will lead to neovascularization or worsening. So yes, if the patient needs injection, I would inject, but yes, I would laser off those areas. And for another thing that is important is to identify any sort of neovascular tissue if present, because that would make convert my diagnosis from maybe severe NPDR to a PDR, early PDR, or rather transitioning PDRs.
Yeah, that was the question.
Yes,
because there seems to be some change in perception what we have been taught and what has been practiced by
Yes.
some.
So these days, what even I have been taught that even if NVE is not there, you should laser off because they tend to progress to neovascular.
Darius,
Right, right, right. Systemically. So what I personally follow that in cases of mild and moderate NPDR, I won't laser. I would just observe. But once it progresses, once it reaches severe and it tends to progress, I see that the patient has a poor metabolic control also. I would definitely laser it. Because one day or the other, he will come back with the worsening thing. But yes, if I have lasered, I definitely know. So one thing is that if it is ischemic, that area is already lost to us. Even after revascularization, that area won't ever have a good visual acuity prognosis. So if you even laser it off, definitely you will help the patient to halt some sort of prognosis. So that's my thinking. That's my personal opinions.
You're very well entitled to have your opinion.
Yes, sir.
so now we call Dr. Darius. He is a famous active retina surgeon in New Delhi. And he will be talking about higher investigations as far as the inflammatory neovascular conditions are concerned.
Good afternoon, everyone. Thank you so much, Dr. Mele, for giving the kind invitation. It's amazing to be here. And I think my work has been made very easy by Dr. Manish and Dr. Abhijat because they've kind of set the pace and they've kind of given the groundwork and the basics. So now I'm basically going to show a lot of beautiful images and pictures. That's it. And then we can discuss them if you like. So when Sir says armamentum newer diagnosis, maybe I'll start in chronological order because ICG is what it's not really considered newer anymore. Unfortunately, people are using it less and less. So I just wanted to just show two cases where ICG really helped us. And then I'll move on to Optos, where wide field imaging is really opened our eyes literally. And then to Octa. And Octa is something where you can see wider also and deeper now with newer modalities, especially the swept source technique. So I'll cover all this briefly in my talk. So just want to start with a case. I'll not do too much theory. The 17-year-old girl who complained of blurred vision in left eye. What do you see in the fundus? I think it looks pretty normal. What do you see in the FA? I think it looks pretty normal. So your ICG helped us. So now look at the late stage ICG. Look at these spots which are seen in the late stage ICG. And very late FA, you see some leakage. So this was a case of mutes. And in fact, there was a lot of discussion was done on this case, etc. And it was a self-resolving condition. So this kind of picked up the diagnosis and saved the girl from having to go through immunosuppressive therapy, multiple tests, etc. So it's important to know these diagnoses to kind of be able to manage the patient in a safe way. Second case, this was a patient who came for a second opinion with drop of vision in right eye, blurred vision right eye. FFA montage looks pretty normal. I think everybody would agree. But you can see the dropouts in the ICG angiography. So this was a case again, of course, managed by Dr. Shishir, who is my hero for inflammation, and started on oral steroids, and thick choroid could also be seen on the EDI OCT. So this I just wanted to kind of tip of the ISOs, but I think ICG is no longer new. We have much newer kids on the block, like ultra wide field angiography, Optos imaging, and my favorite, the dye-less OCT angiography, where wide field OCT has broadened our horizon in a non-invasive manner. So this is traditional 30 degrees. You go wider with the ETDR7 field. With ultra wide field, you're almost seeing 200 degrees with the Optos. And these are just cases, I think we don't need to go details, just been discussed by Dr. Abhijat. The inflammatory CRVO, where you beautifully see ischemia and cutoff zones, it's all delineated. And you see how posterior the ischemic area is coming and encroaching and threatening the macula in this case. Similarly, a superior temporal inflammatory BRVO, where you can see some laser marks which I think need to be tightened, and beautiful collaterals which are forming, you can see in this image. So of course, these you always need to look for any primary cause. Take your friend's help, a physician, cardiologist, rheumatologist. Laser promptly
This is just what we discussed, the controversy, whether you do it only after we see neovascularization, or like I agree with Dr. Abhijit, supposing patient is not able to come for follow-up very much, or you're seeing the progression is very rapid, you may consider doing a PRP laser, and you just treat the areas which are affected. You can spare the normal areas at that time. And I think they work very well. A combo therapy with anti-VEGF or steroid followed by laser works very, very well. Patients, especially where they have even tiny amount of macular edema. Even if you see a tiny speck, I think do the combo therapy. If you only do laser, then they come back with the edema and then they blame your laser for it. So I think this is some small tip I would like to say. Now, what about non-dilating pupil? This is where I think the wide field, the new armamentarium is beautiful, because here you see on the right side and the left side. On left side, through the small pupil, you can get a FFA, of course, but you may not be able to see the zone. You may not be able to make out where exactly to laser. But here, if you see, in the wide field, it's all seen in one picture. And how simple your laser is after that. You can see the nasal areas of CN neovascularization. You can target it. You can do a targeted retinal laser in using the wide field newer technology. Uveitis, so you can see how beautifully the pars planitis has been picked up using this Optos picture. And right up to the pars, so you can see the cotton ball exudates in this patient right at the snow banking, which is seen beautifully. And another case where we can see NVE at the pars plana. So in fact, the ultra wide field FFA has replaced FFO, which we used to do in our fellowship, the fundus fluorescent ophthalmoscopy. That has been replaced by doing a wide field imaging. This is the other interesting thing which we just spoke, Dr. Malia, so where we can do something like treat and spare. If we see well where the areas are affected, you don't really have to go after the normal retina. You can treat and spare. Diabetics, generally I don't follow this, but vasculitis cases, this is some of the cases we do this. We just treat the areas which are affected. Now what about OCTA? So basically OCT angiography, the basic concept is in a static eye, the only moving structure in the fundus is the blood, the RBCs which are flowing through the vessel. And the advantage is you can get depth resolved. So you can see layer by layer vascular layers, and then you can kind of zone in on the area of interest. When you have a combo of swept source plus OCTA, you have a winning combination where you can go wider up to 16 millimeters and deeper 3 millimeters depth. So these are the kind of montages we see. We of course have the classic 3x3 image, which is right in the center, but we're going wider, doing 15x9, and when we stitch all these together, we get a 22 by 22 mm kind of image. And these are the kind of images which really help us see everything without a dye. So just one or two cases. This was a patient who had a superior temporal BRVO with NVE. Laser was done long way back in 2007. So you can see on the imaging, you can see the sclerosed vessel, the laser done. And this is what I was talking about, slicing. So you can see the NV which is raised. So only in a particular slab, if you cut the slab, you see that which is the VR interface. So that's one of the higher slabs. As you go lower, you go to retina surface, you can go down to choroid. So here you can see it beautifully on this wide field slab. And over 13 years, she had a bleed. Vision remains 6A. So a message from here is just less is more, because there's traction. We were avoiding anti-VEGF. We just observed this patient, but it's good to know what's going on. Second patient is a known case of CML. TLC was only 1.8 lakhs. So you can make out patient is a sick patient. Left eye vision has gone down to 660. Pressure is high. Both eyes ischemic CRVO with neovascular glaucoma in the left eye. NVI is noted on the slit lamp exam. A very featureless retina you can see in the right eye. And the left eye also you can see how much ischemia there is, and some CME in the left eye, which is the poor vision eye. And here I want to show how beautifully, if you have a wide field OCT angio, right up to the periphery, you're able to kind of make out this massive amount of CNP areas in this patient. So of course the patient was put on anti-glaucoma treatment, anti-VEGF, and a tight laser was done, and a DLCP in the left eye. So I'd like to conclude with a mystery one-eyed case. This was a young man who complained of blurred vision, and this was one-eyed because right eye was lost to trauma. So we were wondering whether it's because of some inflammatory thing. Is this something sympathetic happening, sympathetic ophthalmia? But no, it wasn't. And these are the kind of images you can make out the stasis, you can make out the dilated tortuous vessel,
And then we got the hemoglobin down, something very simple. Hemoglobin was 17, which is not very common in our population. And when the literature search, one of our fellows was very enthused about it, so they did a PCR for this JAK2 mutation. And then venesection was done for 2 units of blood, and after therapy, patient improved to 6/5. So sometimes these rare things can come which mimic inflammation, neovascularization, and they just need a simple hemoglobin test to diagnose it. So I'd like to conclude. I think today we have discussed the newer imaging modalities, starting with ICGA, which is not so new anymore. We moved on to Octa, which helps us see deeper and wider. And all these tools are a whole new world for managing our cases. So I'd like to thank the entire team at Shroffey Center, and for Sir, a special photograph of Dr. JB looking very, very young, and with him, I don't know how many people can recognize Dr. Shishir, because they are my uvea guru. As far as possible, I stay very far away from uveitic cases because I have luxury of referring to Dr. Shishir. But whenever I don't or he's away, then I have to kind of take the help of my 2 gurus. Thank you so much.
Thank you, Darius. For those who are not aware of the word MEDWS, mutes, it is multiple evanescent white dot syndrome. One thing which you said about if you have a small edema, you will do injection and laser also. What is your take? Why not only injection? That's the question.
So if there's a small amount of edema and the patient has got any NVD or NVE, then I will do the combo. But if there's mild or moderate NPDR or mild NPDR with only edema, I'll only give the injection.
Great. Okay, fine. And you also showed some fantastic images of 22 by 22 octa.
Yes, sir. Yes.
How difficult it is to do it?
So yeah, you need cooperative patient, you need a lot of time, and you need a fantastic machine like a Plex Elite. So I think all those boxes, if we tick, we can get that image.
Okay. So thank you Darius, for making it lively. And Dr. Ajay Arora has also joined us now, and he will be talking about diabetic macular edema. So we have tried to make this instruction course interactive so that on one hand we discuss etiopathology and on the other side we discuss some clinical things so that it becomes more useful and interesting. The idea basically has been again taken from JV sir. He is a fatherly figure for all of us in retina and uvea. So Dr. Ajay Arora, yeah.
For the connection. So thank you, Dr. Malay, for including me in this lovely program.
So till he is getting things done, Dr. Darius, what's your take on treating peripheral neovascularization? How much importance you give to peripheral NV?
This is with regard to which
that
subset?
uveitis patient you showed extreme periphery.
I think it's always good to treat it because it's so far away in the periphery. There's nothing to really lose. So I think we treat it. The other very interesting case which I'm very interested in is a PHCR, peripheral exudative hemorrhagic chorioretinopathy. That's something we've worked a lot on. So those cases also, the standard of care is to observe, but I do find that if there's a large mound, especially one-eyed patients, you give anti-VEGF, and then you do imaging, and if you find the CNVM in the periphery, you can laser that also. So I think peripheral laser is something which is really safe and long-term for our patients.
One small comment from Dr. Manish. Already I think that question has been answered, but suppose if you have a peripheral, how much importance you are giving to peripheral NV with reference to diabetic retinopathy? Dr. Arora, you can also step in.
Reference to diabetic retinopathy.
Yeah.
Diabetic retinopathy is mostly we get mid-peripheral.
Let me qualify my question. Earlier we were looking into that mid-periphery thing, but I think SN guy, Dr. Raman, Rajiv Raman, he has talked about a lot about going into the periphery and looking into for neovascularization, especially with the newer technology. How much importance do you think you give to that neovascularization?
Sir, still when the patients land up to us, we have to treat NVE, whether mid-peripheral or peripheral. If diabetic patient is developing NVE, we have to do the lasers. There is no question about it. But my question would always be, always be skeptical for the branch retinal vein occlusions for other conditions like vasculitis, where there are a lot of collaterals develop actually. So these collaterals actually, even if a large CNP is present, they will not transform into an NVE unless it is very very periphery, which is the watershed zone for the retina. For these conditions, vasculitis, BRVOs, the periphery small CNP will develop NVE, whereas a large vessel block will develop more collaterals and is unlikely to develop NVE. Diabetics, because it's a progressive disease, if you see an NVE, you will have to treat these patients anywhere they are.
And Malay, in cases where we've had patients who have recurrent vitreous hemorrhage, we have operated, we have done a vitrectomy, we have lasered, and then you do a wide field angiography in these cases, and you find that you had actually not lasered completely, and you had left off some small front which needs to be lasered. So that is the importance of NVE. And coming to what you mentioned about BRU cases, so we have had 2-3 cases which I'm just going a little offshoot, where you have areas of capillary non-perfusion in the periphery, collaterals are developed. So in these cases, we have done a micropulse to the periphery without lasering them, without altering their field, and we have kept them stable for about 2 years. So thank you, Mala, again. I'm talking about DME current concepts in clinical management. So I think this is the basic diabetic macular edema, that is a multifactorial condition, that it causes visual impairment that critically impacts the patient's quality of life. And we all know about the classification of a clinically significant macular edema, which you should still, for the exam going PGs, it's important to know how do you define CSMA. And then the DRCA.net and the European expert panel came up with a center involving diabetic macular edema and a no center involving diabetic macular edema. When you have a focal edema which doesn't involve the center, you should treat them with laser, while if you have a center involving diabetic macular edema, you treat them with pharmacotherapy. This is a busy slide, but I think you should learn about what are the pathways involved in pathophysiology of diabetic macular edema, because that helps us in finding the treatment. This was a patient who had come to us with, this was many years back, and then this patient had both eyes clear-cut defined diabetic macular edema, OCT demonstrated it, but patient refused to take any intervention, went into a holistic way of handling himself, did yoga, did a good dietary control, and this is what it was 6 months later, which clearly shows that a good dietary control and managing your diabetes well could help. Metabolic control is extremely important. This patient came to me in the OPD in a multi-speciality hospital, where patient presented, patient underwent dialysis, and patient's diabetic macular edema resolved. Again, saying that metabolic control in a diabetic patient is extremely important. This was a patient who had thalassemia with a hemoglobin not going above 9. So we treated the patient with we could not get the anemia treated, was treated with anti-VEGFs, and subsequently this patient, this was way back in 2008, 2009, it's almost about 15 years back. We went ahead and did a vitrectomy where there was no traction, which probably improved oxygenation to the macular area, and patient did well. And it's now been demonstrated that once you do a vitrectomy in these cases, macula becomes a little better after you have done all other methods of treatment. Focal edema, which should be treated with focal laser without giving any anti-VEGF, so that is again important. You don't have to give anti-VEGF in every patient. When you have an extrafoveal edema, you can treat it with focal laser. Must do an angiography before that. This is just standard giving anti-VEGFs. Patients respond. This was a patient who was 52 years old, diabetic with a hemoglobin A1C of 7.2. Diabetic macular edema. We could not make out the the outer retinal area very clearly with the OCT. Went ahead and gave Avastin. The architecture of the OCT improved. Patient received multiple injections, and patient did well eventually. Whenever you have a tractional diabetic macular edema, these patients need to be operated. And these patients, we can't keep pumping them with intravitreal injections. Identify the tractional process and treat them with surgical intervention. Now comes the point of what is the role of inflammatory factors, and it's been shown that other than VEGF, there are other factors like ICAM, IL-6, MCP1, all these are involved, and they are important as far as diabetic macular edema goes. So these are some of the biomarkers like the hyperfluorescent diffuse diabetic macular edema. You have this hyperreflective spots, the cystoid changes, the neurosensory detachment, and the increased thickness of the inner retina. This is a very nice graph, which actually a table which shows which patients with what findings will respond to the first line anti-VEGF treatment or the first line steroid treatment, and if you put these all together, you can actually treat them with your choice of agent. How do steroids act? They have an anti-inflammatory as well as an anti-VEGF injection. So this was a 57-year-old female, type 2 diabetic, hypertensive, pseudophakic, who obviously had this macular edema with cystoid changes with hyperreflective spots, was treated with Ozurdex. This is 6 weeks post Ozurdex. The macular edema had reduced. Initially, the patient got anti-VEGF, but subsequently we treated the patient with steroids, responded well. This is an old slide of mine. This was in Chandigarh where we had treated the patient Ozurdex. Patient did well. So now is something which I'm using very limited Ozurdex now. I do use, but most of my thing is treated with a suprachoroidal injection of triamcinolone. You can see here that and now we have started using centrifuge triamcinolone. A single injection of triamcinolone given in the suprachoroidal space lasts us almost for about 6 to 7 months, which is, I don't think any other agent gives us that. So this is a lady, and this was my first patient who had come to us when Ozurdex was for some time not available in the country. It was an obese female, had received multiple injections of anti-VEGF and had also received 4 injections of Ozurdex in each eye. You can see here that there's a persistent diabetic macular edema. So we went ahead and gave her suprachoroidal triamcinolone. You can see this is the response on the 14th day, 34th day, and 70th day. So about this effect lasted for about 88 days. Now with the centrifuge triamcinolone, the effect is much more. The other modality that I'm using in our center is a micropulse laser, and there are numerous studies now which show that micropulse laser can be used in conjunction with anti-VEGF. We normally decrease the macular edema to a level of below 450 or 400 microns. Then we go ahead and do the micropulse laser, and we found that number of injections to an extent can be reduced. And it's been shown by the microperimetric studies. We don't have a microperimetry, but it's been shown that the visual field of the microperimetry is maintained as compared to a conventional laser. So this was a patient who had received micropulse, and right in the early days, and patient did well. This is another patient who had micropulse laser followed by cataract surgery. Patient did well. This is a patient with a persistent diabetic macular edema. So sometimes you keep on injecting and the diabetic macular edema persists. So these cases, it's a good idea to do a wide field angiography, and you will be surprised to see that you have NV in the periphery. Go ahead and laser them. Once you laser them, your need for giving intravitreal injections would reduce. So that's what happened in this particular patient. Patient responded well. So these are the biomarkers which correlate visual acuity with OCT and DME. The central foveal thickness correlates in about 27% cases of DME with visual acuity. Then you have drill, you have ELM integrity, ellipsoid zone, which is formerly called the ISOS junction, thickness of the photoreceptor outer segments, and the presence of subretinal fluid. So this has been well documented that if you have which patient would do better, patient who has maybe the macular thickness is the same. If you have a drill, obviously those patients will not do well. and drill can be predicted. It can resolution of it can be predicted about 8 months in advance. Retina has given us very good guidelines of managing diabetic macular edema. So when you have a major cardiovascular event, you should use a corticosteroid. If you have a tractional macular edema, you could again use corticosteroids or anti-VEGF. And otherwise, anti-VEGF is still the primary drug to be used initially, followed by steroids. As I gave you the chart, that is very, very useful. If you follow the chart, we could definitely ease the decision making process. So because of paucity of time, Ajay Dudani has come here to make a talk, so I'll finish off fast. Please remember that if you do a cataract surgery in a patient with diabetic macular edema, please treat a diabetic macular edema well. If you do cataract surgery in such a patient, you might end up in such a situation which becomes a medico-legal issue. So the key take-homes in the end is a good metabolic control with control of anemia, lipid control. Anti-VEGFs are the first line of therapy. Steroids have a significant role to play. Intravitreal corticosteroids act by their anti-VEGF property and block the inflammatory mediators. DEX implants are effective and show a favorable clinical response. We've had a very good response with suprachoroidal steroids, and they are cheap, they are effective, and they have a higher durability than Ozurdex implant. Traction diabetic macular edema needs to be operated. Focal edema needs to be lasered, and you need to do a supplemental laser to NVE and capillary non-perfusion area. We have done few cases of micropulse laser, and it's showing its additive effect to the anti-VEGF agents. Thank you very much.
Great, great presentation, Dudani.
I'm my Dr. Ajay.
Oh, sorry, Ajay Aurora. both are Ajay. So as your presentation was moving, I had so many questions, and you actually have already answered all those questions. Okay. So that's great about your presentation. Yeah, great. Thank you. A great presentation. And before Professor Ajay Dudani joins in, last presentation, we are running almost 3 minutes behind schedule.
Finish fast.
Yeah.
So I think most things have been covered by my esteemed colleagues before me. So I just wanted, my topic was that laser is not dead is what I wanted to say today, As I think Ajay said, micropulse is there, but even the actual laser is there today for us. So this topic was inflammation meets neovascularization in retina. So the thing that came to my mind was Eales disease, where the periphlebitis leads to neovascularization, and we treat with steroids, AKT, anti-VEGF and lasers. So I think that's the epitome where both these things are meeting. And also DME, where we have HRFs, which are macrophages with inflammatory IL-6, IL-1, NOS rising, and they respond beautifully to steroids along with lasers. So this, I won't bore you all with this. So diabetic retinopathy, basically there's inflammation. Control of diabetes leads to, the better the control, the less the progression of diabetic retinopathy. We are very aware of that as per the DCCT trial. There's a genetic basis also to DR. I was just now in the free paper session where they said your eye microbiome might be responsible for diabetic retinopathy. I was surprised to hear that you've got a microbiome in your eye also, So high risk PDR is what I'm trying to say, that we have this. You should never forget that in India, patients with high risk PDR, where they're going to bleed with tractional detachment and advanced eye disease, can be prevented only with laser. So most of our patients come with this advanced stage, and the only way we can prevent that is not by multiple injections, but by laser. And I'll just briefly go through this 1 second. So when you have neovascularization, which can be mild or extensive, it can be periphery or on the disc, and it's associated with fibrous proliferation. That's when laser comes up. You don't want the patient to end up with rubeosis iridis. That's the last thing you want. So this is just one, indulge me with this little video because I thought you all will have very dry talk. So here I always, start with disc convert dissection in these patients with PDR, and see, this is how you get at presentation. And post laser and anti-VEGF, if you have a patient like this on surgical table, they'd respond very much better to our surgical maneuvers also. And I just want to say one thing in diabetic retinopathy, you don't want to end up in this stage, because if you do laser adequately in these patients along with anti-VEGF injections, you won't end up at this stage. So the unmet need and the need for anti-VEGF in patients with PDR, there are a lot of studies which have shown that nowadays we are going into basically role of injections only, but pan-retinal photocoagulation shrinks and scars up the damaged blood vessels, and anti-VEGF can be additive in this, and you can have a synergistic effect of anti-VEGF and pan-retinal photocoagulation, which has been proven by various studies. So these are the various protocols which were done by the DRCR. The protocol S, ranibizumab versus PRP, protocol I, ranibizumab with laser versus sham with laser, and the Rise and Right study which was done. So the protocol S, basically I'll just go to the conclusions. They found that either ranibizumab or PRP are as viable. So please don't retire your laser, especially in India where the patients can't afford these multiple injections. Though the patients with ranibizumab monotherapy did a slightly better vision, and the DME obviously resolved. So I think what I do in my patients is I start with anti-VEGF and I add up with the laser, so you don't require those many injections. So it was also proven that anti-VEGFs like ranibizumab reduce the diabetic retinopathy severity score compared to laser, because laser doesn't reverse the disease, whereas anti-VEGFs can actually reverse the disease. The first time we are seeing that the diabetic retinopathy can be reversed. So that was proven by the ranibizumab studies which were done. The protocol I also compared patients with a PDR, and they found that intravitreal ranibizumab appears to be associated with the reduced risk of diabetic retinopathy worsening with or without PDR. So it will prevent the progression from NPDR to severe to high risk PDR patients with injections. And the Rise and Right study had the conclusion that intravitreal ranibizumab reduced the risk of diabetic progression to PDR patients, and the DRSS did improve in these patients. So this is the PRIDE study which we are not very aware of, which assess the efficacy of ranibizumab with or without PRP compared to PRP alone in patients with PDR. So ranibizumab showed stronger effects on neovascular leakage in areas and area reduction while offering better visual results versus PRP. So definitely a combination works, but even a monotherapy can work, and the results of a combination are much better. So in my practical experience, I've seen that when we do laser patients, we used to do PRP to a PDR patient, used to get a rebound macular edema and the patient's vision used to go down. But if the patient has anti-VEGF in his eye, like I give a first injection in a patient with PDR, and then over the next 4 weeks, I'll finish my PRP. And then I give a second injection, so that the macular edema is stabilized, there's no macular edema rebound, and then the second and third injection can take over. But I finish my PDR, especially in the high-risk patients, within the first month of having my anti-VEGF in the eye. So don't forget, I think Dr. Ajay Arora is a very strong proponent of micro-pulse laser, but even the actual laser does work, and I always do focal laser and not grid in my patients with focal diabetic macular edema after I've given injections, and if it's resistant to more than 3 injections, So I think you should use laser judiciously, treat the microaneurysm away from, I now don't go 500 microns, I go more than 2000 microns away from the central fovea, because you have the additional effect of anti-VEGF. This was in the initial studies of the ETDRS when we didn't have these drugs, So we used to go very close to the fovea within 500 microns. And aim for a very light gray burn. Don't aim for those white burns at the macula, because I'm now 30 years into practice, and I've had my patients whom I've done, dark burns, which I thought was very far away, that laser scar is increased and, encroached my fovea and I've lost vision. So please try to have mild burns and stay away from the fovea, because over years, these laser scars do enlarge. Grid I do very rarely in my patients, at least patients who can't afford laser and anti-VEGFs, but I am not, I'm doing modified grid, that is just like, 1 or 2 rows within the arcades, very well away from the fovea. So again, now this is like, the slit lamp guidelines are very much same, which we are using, 25 years back, and you use the same lenses, or you can use even the LIO. I am more doing LIO delivery nowadays, and all of us are also doing that, unless you have the pattern laser which you are doing. So even pattern laser has, so the advantage is there's much lesser energy delivery here in this, and you can give a multiple number of burns in just 2 sessions in these patients with pattern laser. So this is how the pattern laser looks, and this is how The old laser used to look, and we used to even laser the new vessels directly. So this is the beautiful involution which we get in our patients with PDR. So please, the take-home message I want to say is that the synergy of anti-VEGF and lasers is there for us to stay in India. Though I was speaking to one of my colleagues from Jocelyn in Boston, and they have actually retired their laser in USA, in Jocelyn's, but we can't do that because of the cost constraints. Thank you very much for your patient hearing and indulging me. Thank you.
Great, Ajay. You came very late, so actually we lost some of your expertise here. And the take-home message which I got from your thing is that laser is going to stay, but do light laser away from fovea. And if you combine it with injections, the laser intensity is reduced. Thank you very much for such a nice interactive presentation. We'll have a photograph and hand over the mic.